Go ahead. I started it.
Okay. So, hello, we're students from Nevada State College, and we did our quality improvement project on fall preventions. I'm Haley.
Shayna.
Dan.
Jane. Crystal.
So just to start off, what is a fall? According to Sunrise Hospital, it's described as an unplanned descent to the floor, assisted or unassisted, with or without injury regardless of patient age or cause of event. According to the Agency for Healthcare Research and Quality, each year there are 700,000 to 1 million falls in hospitals across the United States. A few factors that lead to falls is cluttered pathways, medications, impaired gait, and visual changes. So what we did, we researched policies and procedures that can be implemented to accurately identify patient fall risk, decrease incidence of fall, and increase patient safety. We conducted a literature review to compare evidence-based practice with the current practice here at Sunrise.
Okay, so we've identified some of the current practice here at Sunrise, and what you guys have is a fall risk assessment is completed at time of admission to identify fall risk patients. Patients who have received any sedation or anesthesia following procedure are automatically put on a fall risk. If patient is assessed as a high fall risk precautions are added to process interventions. And then plan of care will be reviewed and revised as needed by the RN during their shift. And then post-fall huddle form are completed after all falls and forwarded to the risk management and the unit manager or director. Falling star are placed outside of the room with the patient suffering for any fall, so it should be sticking right outside their door. And then the fall prevention protocol right now at Sunrise Hospital. The interventions for all patients include bed in the lowest position, brakes are applied and make sure that they're locked. The call light buttons are, we have to make sure they're within reach. Educate patient and family on safety techniques. Make sure that all rooms are obstacle free. Appropriate lighting, minimum noise, orient patient to room and surroundings in their room. And then the interventions for high-risk patients include make sure they have their yellow armbands on the patient, yellow non-slip footwear, and patient safety monitoring devices. And then hospital staff must remain in arm's reach of patient during toileting or when they're showering them. And then patients are assigned to a room near the nurse's station if they're in a high fall risk. And then the patients are assisted doing their ADLs and including toileting. And then there's a form which is the family and fall risk agreement that's given during admission. So the nurses, when they're admitting the patient into the unit, they have them sign this form right here. So it basically talks about like the do's and don'ts of about the patient in the room, like as far as safety goes. So then they have them sign that form, and then they make copies, and one is left in the patient's room, and then the other one is put in the patient's charting.
Okay, and then so like we did a literature review, we all had our own article and we kind of picked it apart, and it was just to get some evidence-based practice to compare it with the current practice here. So for example, one of the evidence-based practices we found was involving patient and care using the fall self-assessment versus like what they're doing here now, which is the fall risk assessment. This one just gets the patient a little bit more involved in doing an assessment for themselves. Another one is to educate the patients on all fall risk factors as evidence-based. We kind of have noticed that we haven't seen a lot of patient education, a lot of consistency with the nurses regarding anything like fall risk and things like that. We also suggest using a gait belt every single time, and we have also observed that a lot of like the whoever is working with them, they'll just use the pants to move them instead of using the gait belt. Sometimes it's on them and it's not being used, or it's not even within reach in the room. Another evidence base would be assessing the patient's needs during hourly rounding, and another one would be staying in the patient's room while they use the restroom. And we kind of noticed here that like the nurses aren't really doing the hourly roundings as often as we, is ideal, because within the patient rounding, you could do like toileted scheduling and things like that. And so we do propose a few things, and I'll just talk about it really quickly, but the fall risk assessment tool, this one helps the patient understand why they're at risk. So you kind of give them their own self-assessment, and they understand and they see why they're more at a risk for falls. And then another thing would be, just help involving them in their care. So when you involve them, like doing the self-assessment and things like that, then they're able to, be aware of, the fall risk factors. And then we also have the magnetic reminders and the use of the gait belts and stuff. So, yeah.
So there are no fall risk self-assessments for inpatients. They're all outpatient based. So what I did is we put together we adapted some of the fall risk self-assessment outpatient tools into a tool that can be used as an inpatient. And what it does is it helps the patient identify, like, hey, maybe I really am at a risk for fall, because in the research, there were patients who were at risk for falls but didn't really realize almost all patients underestimated their fall risk and overestimated what they're capable of. So in answering these questions, it'll help them realize that, hey, I am a fall risk. So the questions are on the paper you have in front of you. Well, they're more statements. I have fallen in the past year. I walk around using a cane, walker, or other assistive device. I do not feel strong as I usually do. I take medicine that makes me feel dizzy, lightheaded, or tired. I have to use my hands to push or hold on to something when I get up. I am worried about having a fall. I have lost some feeling in my hands or feet. I sometimes need help with bathing, dressing, eating, or cooking. Sometimes I am afraid I might fall. I already read that one, didn't I? I usually only eat 1 or 2 meals per day. It has been more than 2 years since my last vision exam. And those are all assessing the risk factors for falls. Let's see. So then we have this tool itself is not evidence-based, but what is evidence-based is getting the patient involved in their care. So this fosters participation by the patient in making decisions regarding their own care, using the sense of control, and helps implement the interventions that we want to implement. It gets us all on the same page. Instead of us just telling them something, they're helping to decide on something that's important to them. So they're more likely to implement these interventions. So the interventions selection tool that we came up for the patient, it's consisted of several statements, and the patient chooses the few statements that are most important to them, and then we implement them maybe one or two at a time, gradually. So I will learn and demonstrate how to use the call bell to call for assistance. I will call for assistance when I need to get up or I cannot reach one of my personal items. I will remind the staff to assist me to the bathroom every 2 hours. I will assist in keeping my room clean and my personal items out of the walkway. I will remind staff to leave my important personal items within reach. Personal items that are important to me are blank. I would like help with day-to-day activities. These activities that are important to me are, something like shaving, washing my face, etc. So they're not getting up on their own to try to do these things. And I will let the staff know when I am feeling weak, dizzy, lightheaded, or not feeling well in general. And those are things that the patients can help implement, and they would choose the few that are most important to them, and we would implement them gradually, a few at a time. Because research does demonstrate that when patients focus on only 1 to 2 fall risk interventions at a time, they're actually more effective than trying to focus on a whole bunch at once.
Okay, so as a group, we also created a reminder tool for the unit. These ones are samples. They're magnetic. So with these tools, the healthcare staff can stick them on like the door frame or in the bathroom or even on the magnetic board. So this one here, the Don't Leave Me Alone, this one he can put in the bathroom because healthcare staff can maybe leave the patient in the room. So this is a reminder just not to leave them in a room and then they're within the arm's reach. And then we do have another one that you can put on the board or the door frame. So this one is a reminder tool to plug in the bed alarm and then to turn on the bed alarm. So these ones are cool reminder tools. And then, so basically for the conclusion, patient safety is always number one, of course. And then overall, the rehab unit is low on falls, but it doesn't help to implement these interventions, such as the patient-centered tool or these reminder tools. The fall assessor reminder tools, and then also patient-centered care as well, being consistent with the patient-centered care, such as like education, continuing education, and continuing assessing. So just with it, not just in admission, but throughout the shift, any change in the patient's like status, and even with the family as well. And then and basically, the Sunrise Rehab Unit nurses are in the perfect position to implement these strategies. Thank you. Thank you.
Have any questions?
So you guys, so is basically the Morse fall risk scale obsolete now?
Is it? Is that what you're asking?
Yeah, you guys said that you guys didn't find anything that was inpatient wise.
So the current inpatient assessments are for the nurses to do. There are no inpatient self-assessment. So when we're doing the assessment, we may not be telling the patient that, hey, you're at big risk for a fall. These are the things I need you to do. So having them do their own assessment, like the one we proposed, would help them to realize that they are at a risk for a fall by doing it themselves.
They or their family, because sometimes there's
They and
patients
their
up here
family even, yeah.
that
and or.
that
High-risk patients
don't
are confused.
understand.
Yeah, so
and
obviously the tool is more geared towards patients that are learn oriented. However, if a patient is not, then we could always give it to the family to help them realize, hey, this my parent or whoever is at risk for falling.
I also suggested that they put, if that self-assessment was to be implemented, that it be signed and a copy made, and
So-
one copy in the room and the other copy in the
So
patient's
the intervention
chart.
tool, I think, would be great to add in addition to the fall agreement that you
Right.
guys already have in place, because currently you guys aren't helping them to choose interventions that are important to them. You're basically laying out a groundwork. Hey, this is what we do. This is what we expect you to do. But in just briefly going over a piece of paper, having them sign it and putting it in the chart doesn't mean that they understand it. So having a tool where they could go through and together with the nurse choose the interventions that are most important for that particular patient. Not only does it help tailor care to that patient, but it helps facilitate involvement in the care, and then we're all on the same page because they know what they want to do and we know that we want them to do.
That's it.
Okay. Thank you.